First of all, I think I have to thank Jean for this very fruitful conference. We only into the first part of our conference, and yet I think, I have my role explained, my task explained as a chairman for the Elder Commission. The task is so difficult. You have, seen the, different parts of the policy that we have to deal with. And I hope that by now you should have sympathy for the kind of work I do. So be sympathetic. Now, this session, obviously, we are into, I think, the meat of our conference, so the ethical challenge for dealing with chronic illnesses. Now, let me steal 1 or 2 minutes to bring this session into focus. Longevity is both a celebration and a burden, depending on which side you're on. If you are healthy, if you live into old age with a kind of mobility that you want, obviously, it's a time to celebrate. But if you're ridden with illnesses and, if you are carried with pain, and obviously one more day you live would be pain to you as an individual. Now, of course, when we move to the level of the family, your family members would have the same feeling. However, when we look at longevity from a societal perspective, they're bound to be costly. So how to deal with this question, whether we should spend more money like what we have been discussed already, and if we want to spend more money, should we spend in primary healthcare or in tertiary or secondary healthcare? Endless debates. I don't attempt to look at all those issues right now, but longevity with advances in technology brings in even more controversies. When people's life can be extended with facilities that's artificial, so should it be a decision for doctors or should it be a decision for the patients themselves or indeed, for the family? How do we exercise what we call advanced directives? So that cuts across all disciplines, all domains. Now today we have 3 experts. So we have Victor, who you know very well globally and internationally. Timothy, of course, there's a name, household name already for Hong Kong, so I don't need to introduce for the audience being here. And of course, Michael, when you look at our brochure, you also realize that Michael is an expert looking at medical ethics in this issue. So without further ado, let me pass on to Michael as our first speaker, and please.
Well, thank you for that kind introduction, and thank you also for the invitation to be here today. It's nice to be back in Hong Kong working with CUHK, and it's also nice to be able to start and open up this panel discussion. I think there are many different kinds of ways in which this topic could go, as Alfred illustrated in his introduction. Victor, in the opening keynote, presented an overview, very brief overview, of some of the sort of practical day-to-day ethical dilemmas that the management of chronic conditions can pose around confidentiality, privacy. We might also think about the negotiations of consent, for example, in care and treatment in this context. I want to sidestep those issues in my reflections, and I want to focus on a different kind of question. It's a more foundational question. It's a question that Jean Wu and Michael Guzmano hinted at in their previous comments. I want to suggest to you that there's a rather significant and important normative gap in much of the ethical discourse that we have around the management and treatment and care for people with chronic illnesses and other long-term conditions. So that's my focus today. Before I move on to the gap, I want to start by looking at some of the progress that ethicists have made, I think, in formulating the values that should underpin the management of chronic conditions. So the progress thus far, I think it's very important to note just how things have developed in our theorizing around chronic illness and long-term care, perhaps more generally, in bioethics. So the very fact that there's a conference to launch a new centre of bioethics focusing on ageing and chronic illness, I think, is quite an illustration of how much the field has progressed away from the kind of standard, trendy, sexy topics around enhancement or acute healthcare. And so we transformed this sort of backwater of bioethics into the front stage, and I think that's itself worthy of note. One of our, I think, important developments is the ways in which we've rethought and reimagined the value of autonomy such that it's fit for purpose in the context of chronic disease management. So in a classic paper on chronic disease ethics, Art Kaplan and colleagues from I think originally from the Hastings Centre project in the late 1980s, produced a wonderful, really important piece of work where they draw upon two different kinds of metaphors to show how autonomy differs between the acute and chronic context. So they talk about how, in the context of acute medicine, we can see disease as a threat to the stable preferences and values that individuals have prior to the onset of their condition. And we develop sophisticated consent procedures to protect the individual self against this temporary challenge to their authenticity, if you like. Now, quite importantly, that model of defending against the attack of disease doesn't really fit for the chronic disease context. And instead what we have, I think, is their metaphor of negotiation and diplomacy, where we reconceive the self as it's threatened by the many different contours that long-term conditions and chronic illness can impose upon us. So as our conditions evolve over time, in particular ever-changing social and familial context, and under different kinds of crises, we need to negotiate and promote a person's autonomy as their values and their desires and preferences continue to change and are modified when living with those kinds of conditions. And that's a hugely important observation, and so important that what I would suggest actually leads us to challenge how we think about autonomy in the acute setting as well. Over and above our way of thinking about autonomy, there's also been important advancements in how we can think about justice in the delivery and provision of care for those with chronic conditions. So we're better aware now of what kinds of obligations family members and professionals have towards those with chronic conditions. We have had sophisticated analyses, for example, of the obligations that adult children have towards their elderly parents, whether they have obligations to pay for or provide care, for example. Obligations to family caregivers and what they consist in, and broader questions about the evolution in the nature of the workforce issues around social and transnational justice in the provision of care to those with conditions of these kinds. So a lot of progress has been made, but I want to suggest there's one area where we have made relatively little progress, and it has significant implications for how we think about policy making and practice in this setting. And that's the question about what the care provided to people with chronic diseases or other long-term conditions is for. To put that question slightly differently, what does it mean to do good in the provision of care, treatment and support to those living with these kinds of conditions? Or what is the purpose of the multiple forms of interventions that we put forward in these environments? For those of you who prefer a principlist account of bioethics, how do we flesh out or substantiate the principle of beneficence so that it's fit for purpose in decision-making, both in policy and practical terms, for the management of chronic diseases? Now, an oversimplification, but I want to suggest that in acute care we have a relatively stable account of the purpose of our interventions. And I do say this slightly through gritted teeth, because I know how controversial and oversimplified it is, but the idea of curing or treating disease, I think, is something that we can identify as being what the business of healthcare in the non-chronic setting is all about. That is not a primary feature of the management and care of people with chronic diseases. So the question remains, what are we trying to achieve? The question Michael Guzmano recently posed, when we provide care to the individuals of these kinds. Now, this is not purely a theoretical problem, and I want to make this presentation less abstract than it might otherwise be. And I want to give you an account of some work I've been doing with directors of adult social services in the UK, who are struggling at a time of austerity to cut significant amounts of funds from their adult social service budgets. And as you may know, in the UK, we have relatively integrated services for some chronic conditions. So local government managers are in charge here rather than NHS managers. These are government workers, as it were, in local authorities. And they were called to, we had a conference, a meeting where they were basically trying to come to terms with how to cut millions of pounds from their budgets in ways where they could justifiably decide who should no longer receive the care they were provided to already. And a number of cases were presented that I think illustrate the kinds of problems I want to talk about. So here we have a 38-year-old man who has lived with schizophrenia for 20 years, currently living alone with the support of primary care and outpatient mental health services. This man engages in few activities, but he recently told his occupational therapist that he's now interested in football, a hobby that he pursued as a teenager, but had abandoned upon the onset of his illness. The man suggests that his team, the mental health team, could buy him a season ticket to go and watch his local team play football. The therapist supports this idea and reports to her manager. The manager is uncertain if this is a good use of public resources. A comparator case, exactly the same set of circumstances, but here the man is suggesting that the team buy him a widescreen TV so he can watch his local team play football on TV every week. Again, she supports the idea, but the manager's uncertain about whether that's an appropriate use of public money. So we spent a long time trying to work out whether one or either of these situations was more or less justifiable. We're talking about £1,000 pretty much in both cases. Is that a significant and appropriate use of public resources? Is one of those use better than the other or not? And we had some good discussions about that. I think there is an argument to be made that one is more defensible than the other, and that indeed they are potentially defensible in some settings. But as we went through our discussion, it became increasingly clear that people more generally were concerned with just how to even think about whether this was the right kind of interventions to be offering to people with schizophrenia in circumstances like these. What we're trying to do was raised as a question in that kind of context. And concepts like quality of life, like well-being, like we just do the right thing, were thrown around, often without substance or without content. And that's the nature of the problem as I see it here. So this is a schizophrenia case. I could have given you a whole range of other examples to do with aging. We have fascinating discussions about older people with multiple sclerosis who are being sent on Caribbean cruises at the taxpayer's expense in lieu of respite care, for example. And again, questions about whether sending somebody on a cruise is an appropriate use of resource when respite care is both available but considerably more expensive than this alternative. So what I want to do now is to review, from a policy context in the UK, 4 possible ways of filling in this gap, this normative gap in accounting for the good in the provision of services of these kinds. These are 4 kinds of examples, 4 ways of substantiating this idea, this notion, drawn from different components of contemporary health and social care policy. And I'm going to suggest there's problems with each 4 kinds of accounts. And I apologise that my focus here is on the UK policy context. I'm no policy expert, so I really just talk about what I know, but I'm sure in your own national context you can identify similar kinds of policy developments that are comparable to what we're seeing in the UK. So which way forward to fill in this normative gap in accounting for the good of chronic care services? Well, one suggestion, perhaps, is that we don't need to fill in the gap at all. Rather, autonomy is the only value that we need to appropriately guide the development and direction of services of these kinds. So on an account like this, the purpose of chronic care is simply to enable a person to pursue life choices in line with his or her changing values, preferences and desires. We don't need any additional account of the purpose of the service. If fleshed out in practice, we're going to look like something along the lines of care providers as life coaches, essentially, helping someone to navigate through and develop themselves as individuals under these trying, life-transforming circumstances. Now, I don't want to read too much into what Art Kaplan and his colleagues said in that classic paper, which is, say, 1988 rather than 98 there, but you might think that they point towards this kind of move when they suggest at the end of their paper that chronic care medicine must create within itself a holistic, supportive environment where persons with chronic illness can construct their own lives in a meaningful way. Anything goes. The construction of a meaningful identity is the purpose of the service. We might see evidence of this in policy context in the UK, for example, through the move towards replacing the provision of a service to somebody with all kinds of health conditions to the provision of a budget so people can buy their own services. We give people a pot of money and they can choose what they spend their money on, whether it be in terms of the social care or in the provision of a healthcare resource. They're in charge of their own budgets. They can decide what their money is spent on. Another way of thinking about autonomy, but developing the concept a little bit, is not to think about autonomy here as a value in terms of respecting the person's self-determination as an intrinsic good in the provision of a service, but to modify it in a way so that we think about its value simply in terms of the outcomes that result if we give people control over their lives in this kind of way. I mean, this kind of formulation is essentially to borrow from the pages of John Stuart Mill to some extent. So we see this in this move generally in conceptual terms towards preference satisfaction kinds of accounts of well-being, that the good life is a life lived freely where people can choose to live in ways that they think are going to be best for them by the satisfaction of their preferences in their own terms. And again, in policy context, in the evaluation of care services, we see the move from patient-reported outcome measures, PROMs, in the UK towards patient-determined outcome measures, the idea that patients determine what the goods are for themselves, and the services respond to make sure that they meet those goods as articulated by patients themselves. Now, whether we take autonomy here as an instrumental or an intrinsic value, there are problems, I think, with relying on the value of autonomy to do all the normative work in answering the question I posed originally. It's counterintuitive, indeed it's quite bizarre, I think, to account for the purpose of chronic disease management in sole terms of meeting the modified and ever-evolving wants of people who are recipients of these services. And of course, in relation to the original resource allocation problem, these kinds of accounts of autonomy are going to give us no guidance in how we differentiate between healthcare interventions for different people. Autonomy is the value that we don't bring to the table when it comes to determining problems of resource allocation, because we're choosing between the autonomous preferences of different individuals who both make claims on that resource in their own value-laden terms. So I don't think that an autonomy-based account is sufficient. So how else might we move in policy terms to think about filling in this gap? Well, we see in the UK the attempt to bolster autonomy with other person-centred, non-consequentialist values. So the UK is trying to move simply beyond this idea of giving people choice and control over services to instilling the values of dignity and compassion, for example, in how people are treated when they receive care for their chronic conditions. Again, however, moving towards these kinds of non-consequentialist values looks to underdetermine the account of the purpose of support that we have to offer. Like autonomy, they rightly get at something important about how a person should be treated when being cared for, but they cannot in and of themselves constitute an account of the value or purpose of that care independent of that account of how a person should be treated. So I don't think those kinds of accounts are going to do the work either. What about substituting a modified account of the purpose of healthcare? So, like we have a clear account of the cure or treatment of disease in the acute setting, perhaps the purpose is simply the management of disease when cure or treatment is not a possible road to proceed down. Here we have a remedicalized focus on health interventions of certain kinds, a focus on symptom control, for example, on medicine management and similar such interventions. And we see in the UK context, with the move towards assistive technologies for the remote monitoring and management of chronic conditions, that this is a very common way of thinking about the purpose and the refocusing the purpose of our interventions. But I would suggest that not in every single situation, there are going to be some accounts, I think, when this is an appropriate way to think about the value of the service. But in general terms, countless social scientific studies show us something important, that this kind of account on the management of health conditions and symptoms misses about the effects that these kinds of conditions, in some senses, can have on people's lives and what they come to experience in relational, social contexts as they are enabled or disabled from doing certain kinds of things. It's a poor account, I think, of the overall effects that such conditions have on human beings who are experiencing them. So where do we go from here? Well, that's the question I'm going to leave you with. Just to go back to basics to open up the discussion, I want to suggest that we might usefully revisit this question that Kaplan and colleagues ask us to visit, which is the impacts that the onset of chronic diseases have. Their focus is on the ways in which these chronic diseases can disrupt these stable conceptions and values that people have, a crisis of self-determination that has significant implications for conceiving of the appropriate respect and promotion of autonomy, for example. But importantly, these chronic conditions can also impact on people's agency in a much broader sense. They can actually prevent people from engaging in a whole range of activities, opportunities to flourish or function in certain kinds of ways in the world that we commonly recognize amongst ourselves as being an important part of the good life, of the life lived well. And that, I think, that recognition is a useful place to rebuild an account, or to start to build an account perhaps, that is distinct from the policy developments we've seen recently, but that would have some significant ethical foundation. Thank you very much.
Thank you, Michael, for a very thoughtful but yet very, again, debatable perspective looking at medical considerations. Our next speaker, so Timothy, might be able to guide us to look at very specific circumstances.
Thank you, Chairman. I'm a practicing geriatrician, so what I'd like to do is to show you a few cases that will stimulate some discussion, hopefully later on. Some of the content I disclose is quite provocative. It's certainly not the stand of the university. It's my own personal view. I think several speakers have already highlighted the drawbacks and the limitations of our healthcare system. Just to highlight the main points. The first is the public health funding is limited to hospitals, and we've discussed about the lack of primary care. But in fact, we do have primary care, but just in the private sector. And the emergency rooms are overcrowded because it is very cheap and only $100 per visit and open to all. And our public hospital services are very affordable, only $15 on average per day, and free for the poor. So it's a very good hospital service, and is a service, public service, that is highly valued by Hong Kong people. And as you can imagine, the demand for this would be very big, and in my view, the government is trying to, the only way that we could control demand is to get people to wait. So if you have got a flu-like illness and you choose to come to A&E for consultation, it would take you an average of 10 hours of wait. Okay? Whereas if you go to a private doctor, you can do it in an hour. So that's the choice people have to make. Chronic disease management, I think most people will accept that continuity of care, lifestyle modifications, and early interventions for any complications will lead to better outcomes. But to deliver such a care in public hospitals is very challenging because the sheer volume of patients, the lopsided sort of funding systems attract a lot of chronic patients to public hospital outpatient clinics. A lot of people simply cannot afford private care if you have a whole range of chronic conditions. And there's poor communication between private sector and the public sector. So the dilemma is here for those of us who work in public hospitals is that the better we do, the more patients we have, and consequently longer waiting time. So it's a game that we can never win. At the moment, the waiting time for specialist outpatients is getting out of hand. Sort of, for example, urology in some places, 2 to 3 years. For an inpatient who wants to have a CT scan to exclude cancer, they have to wait 6 months if you don't pay for it. If you pay for it, then that's just how we tell the patients, usually you have to wait 6 months, but if you have the money, you can have it tomorrow. Just thinking about my geriatric outpatient clinic in Prince of Wales Hospital, some of us see 12 outpatients in the morning, while others see 25. So which are the better doctors? You know which category I come under. So what kind of doctors would you like to see, or would you like us to behave? Long-term care, I think, is the major problem, which has a lot of impact to the quality of life of elderly, and also account for many of the hospital admissions that we are seeing. Most chronic patients, chronic disease people, they prefer community care, no matter how disabled they are, rather than away home. I think that's pretty clear. And also with prevention and active interventions, we can hope that people can stay healthy and independent, and they don't need away home. So this is something that we should strive for. But we should also accept that whatever we do, people are going to be getting older and older, and people are going to be more and more disabled, no matter what you do. That's the fact of life. And as Professor Ip highlighted, there'll be less and less young people around. So, and the families are getting smaller. So it's inevitable that people will have to be looked after in an institution or at home. But not to worry about Hong Kong, we do have a lot of old beds, okay? Every 11 old person age 65 or older, there is one nursing home bed waiting for them, okay? So we're not short of nursing home beds. But the only problem is that only a quarter of them have public money, public funding. All the rest are private. You might wonder why we are so rich, so many private homes. I'll come to that. The Savannah homes, waiting time, well, as you can imagine, is 3 to 4 years. Okay, and there's a test that you have to go through to make sure that you are dependent enough to get onto the waiting list. The reason why we have such a great demand for Savannah care, well, partly is because community care is not well developed. Caregivers are stressed, and there are also financial incentives. The subvention is not means tested. Anybody who can get into Savannah home, you just have to do the waiting. Once you get in, you just pay $2,000 per month, no matter how rich you are. This will become a increasing problem or problem in the future as our old people become richer. We cannot assume that all old people in Hong Kong are poor. They are getting richer all the time. In fact, some of them are much richer than the rest of us. And another reason why we have this great demand is that there's a long waiting list. So if there's a long queue, it's better to join the queue rather than waiting. Private nursing homes, they are not private. 90% of them are funded by Social Security. And the Social Security, and it's not a government policy, it's by default. Okay, this funding is by default. And the Social Security money maximum is about $700 per month. The only good thing about this is that it's open access. Anybody can go in. But as you can imagine from this price tag, you can know the quality of care that you can get. I imagine in US and UK, $700 can buy you 1 week of care. Poor care leads to functional decline and death. Although I don't think anybody has done a case control study to compare outcomes of people in private homes compared to Savannah homes or own homes. Again, there's financial perverted incentives for low-income families to send their elders to private homes. When I arrived to this very nice building, very impressive building, I thought about deleting this slide. But I think you should know. It is not typical. I'm not saying that it's typical, but it's certainly not unusual. So, let's come back to the hospital. Well, every day in our geriatric wards, we have people that chronic sick and they're disabled and they don't have lack of family support, not a lot of social services that can give them support. And the families know that as soon as they leave the door, they will be on their own. So it's not surprising that they are very reluctant to have them back. So very often we have to send them to private OH homes. About a quarter of our hospital discharges are to private OH homes. So whatever we do with rehab, a quarter of our patients cannot be managed at home. So the question is, if from time to time some families would say, well, we've looked around for private homes and we've found nothing that we feel comfortable with. My mother is just too disabled and the amount of money is just too little and I can't find a home that I feel comfortable with. And they say, well, the only solution is not to go home and just stay in hospital forever, hopefully. Okay. So, and that's sort of the problem we have been facing all these years. But from the ethical point of view, are these families acting irresponsibly? Is it ethical to discharge them in the first place? And what can be done to discharge these patients? So we call these patients the discharge problems. But in fact, there are a lot to think about. Dr. Dunn just now mentioned about autonomy. And this is this very important principle in clinical practice. But in fact, for the chronic sick, I think it is very difficult for them to have full autonomy. They are dependent on the family, they're dependent on society. The life choices are really very limited. How far should professional society go to respect the autonomy of these people? Give you an example. A recent lady, 85, admitted with a fall at home. She had mild dementia and lived with elderly husband. Husband wanted her to go to OH home because he cannot cope anymore and he's ill himself. But the lady said, no, I don't want OH home. Okay, I must go home. I love my husband. My husband will look after me. And we know that community care is limited. For one thing, we can't start any home care any sort of quicker than 4 to 6 weeks. And so it's very likely that this lady will be placed in a private OH home as a solution. And we know what's going to happen to this lady. She's going to be restrained because it's too dangerous for her to walk about. And she'll become immobile, deconditioned, and become a typical sort of so-called end-of-life cases. So, are we going to respect the autonomy of the husband or the autonomy of the patient? End of life, all these old people, the other doctors mentioned, somebody in nursing home, when they have a fever, they're always sent into hospital. And in fact, it's increasingly difficult for them to die because we are so good. The acute hospitals, we are so efficient in saving lives. We have so many means to save lives. We have resuscitation, although our success rate is only 10%, but still 10%. And tube feeding, and if you are not eating enough, we put a tube down. And if you pull a tube out, we tie your hands down because it saves lives. But we know in the last survey that most old people do not want these things, okay? Even though they are in nursing homes, but they don't want these things when they become critically ill. But then when patients are critically ill, they become mentally incapable, okay? Even though they haven't got dementia, but when they become seriously ill, they can't even say anything. And then nowadays we go to the families. In the old days, the doctors make the decision, but now we go to the families and you say, oh, you have this, you have that, choose. And so the families have great say in the choice. And I did a study of 55 family caregivers of nursing home residents with severe dementia. And I've noticed that very few of them knew anything about life-sustaining measures, and they also, most of them would prefer life-sustaining measures to keep the loved ones alive, although they knew that the quality of life was pretty poor. So there's a discrepancy of what old people want and what the families want. So lastly, I leave you with this very difficult case. I went to visit a very nice nursing home, subvented nursing home. You can see with the furniture, there is a reminiscence corner. So they've taken the extra care for people with dementia. Is actually one of the best in Hong Kong. And but then I heard some noise coming from this lady. And she was just shouting and shouting. And the history is that although she looked quite well there actually, but she was very wasted and not eating. She's got dementia and refused to eat. And she went in hospital and they put in a tube feeding to force her to have the feeding. And because she didn't want the tube and pulled it out, and they restrained her. So for the last couple of years, she has been living like this, restrained to a chair or bed with a tube in the nose that she doesn't like. And in response to this, she kept rocking herself like this and shouting all day and night. Very distressing, even for the staff, who believe that they are doing a great job for dementia and etc., giving great care, but nobody seems to be able to do anything about it. So the question is, has this lady reached her end of life? Is it appropriate to feed her? And is it appropriate to restrain her? That's another question. And Dr. Dunn suggested that let's talk about dignity, but how do we define dignity? This is a comment, a couple of geriatricians in mainland China visited our unit, and in her letter, in the final words, that's what she wrote, wish your work would become more civilized. It was meant to be a compliment, not an advice. Thank you very much.
Thank you, Timothy. Timothy has touched a very sore point of my policy area. Every year we've been asked to answer to the Legislative Council for how many elder residents, elder applicants for nursing homes that we were able to place. And of course, no matter how many government actually, utilized either from the maintained sector, publicly maintained sector, or the private nursing homes. We still maintain a sort of waiting list for 30,000 every year. But among that 30,000, about 3,000 died every year before they could wait for a place. Now, obviously, the reason for that are very complex. But Timothy actually raised one of the key points that many applicants would want to get into government-maintained homes simply because private nursing homes are not up to their standard or expectation. Now, there are many reasons for it, partly because government at one time, or still we are doing it via means of voucher, so-called money follow elderly kind of thinking. But as soon as we raise this point, we have a lot of opposition from our legislators saying that, why should we, using public money to subsidize private business? So another ethical question for you. So without further ado, I think I would like to invite Victor back onto the stage.
Can I speak from here?
Please. And if you could actually offer some solution for the kind of systemic problems that we are facing, that would be great.
After the previous very depressing cases that I've just heard, I was going to suggest that Dr. Dunn provide the answers based on the concepts that he so brilliantly presented to us and that I found illuminating. But since I'm supposed to speak, let me, while he thinks about that, I'll be short. And I'm going to change the nature of my remarks to raise some issues that have not yet been raised. I think they're perhaps issues for the future, but I do believe they are important issues, and they have to do with quality of chronic care. First, I could just answer your question, Dr. Chand, about longevity and whether I believe it's a noble goal, and I don't think that's a goal for anybody, longevity in itself, without some adjustment for quality of life. And I think after these cases, of course, that raises other issues of how we measure it, but longevity in itself, for me, is not a goal ever to be pursued without some qualification of quality of life. We now know in the field of chronic disease and in the field of healthcare that one of the greatest inequalities that has not yet been mentioned is not the problem of access, but the problem of quality. Systems of social insurance, private insurance in the United States as well, which have detailed data on where patients are being treated and what the results are, know very well what the probable outcomes will be for patients with chronic disease. Let's just take heart disease to begin with. Here's my question. Based on the data that health insurers have about physicians and about their place of practice, let me make it a real case. We have risk-adjusted mortality rates for coronary artery bypass surgery in the state of New York. One can quibble about whether those who rank 1, 2, or 3 are really significantly different, but few would quibble with the fact that those who are 93, 94 are probably worse than those who are 1, 2, or 3. This information is now available for all patients and their referring physicians in the United States, in New York State. The insurance companies know even more about where results are likely to be better. Patients can consult this on their own. They rarely do. Their referring physicians can consult this. They often do. My question is there an ethical obligation of those working for the insurance companies to make this information transparent to all patients who will be getting coronary artery bypass surgery? And the same could be said for cancer treatment and other kinds of treatment. I said that's a future issue. It's not on the agenda, and no one's raised it. I believe it will be on the agenda. Let me give a few more cases which are not in the future, but right now in the present. I'll begin with an easy case. Interventions to improve access to screening and primary care so as to more effectively manage and prevent the exacerbations of diabetes, of asthma, of congestive heart failure. There's a study from the RAND Corporation in the United States which suggests that 59% of patients in the United States do not get the care that they should get according to the practice guidelines. If the insurance company sees that the patient is not getting the care that the guidelines suggest should be followed, do they have an ethical obligation to inform the people who are paying their insurance premiums that they're not getting it, or is that not their business? Is that just the business of the doctor? Well, there are questions of autonomy, there are questions of paternalism, there are questions of what you termed so beautifully consequentializing autonomy. I think that has a role there. And I don't know the answers, but I can raise the same kinds of questions. You can. That too. For people, let me take the US case. For people with private insurance in our market-driven system, Alistair, in contrast to your National Health Service, which evidently is not market-driven, but I think it is, in part. We have this, private insurers have this information, and they act on it in different ways, depending on what the nature of the premium is, what their philosophy is, how many members they have, and not much to do is made of it because they're small organizations, relatively. We also have this information for Medicaid beneficiaries who are poor people, very, very poor people in the United States, with 50 different programs in 50 states, all of whom do this differently. Some mandate managed care, some mandate guidelines, some follow very carefully, some don't do anything. For Medicare, there's one program. There are guidelines for managed care programs, which themselves differ. But the responsibility for Medicare under a national health insurance program only for older people in the States is to leave most of these decisions largely to the doctors and to the patients and not to intervene too much. For the uninsured in the United States, they are the ones who don't get the screening always, don't get the primary care, end up in the emergency room. And so the chronic disease is not being well managed at all. And they're only getting the services too late. But since we provide care for everybody in the United States who comes into the emergency room with a serious condition, they have the access, but too late. What's the responsibility? I mean, this is a major ethical issue just because they don't have the same access as the others. Let me take a slightly different case, the case of a national health insurance program, French style. Here, everybody's in the same boat. There isn't this pluralistic American market-driven kind of case. Everybody has the same benefits, everybody has the same insurance, and since it's a national health insurance system, there's an extraordinary amount of information. That system has so much information that anytime you want to do something with it, it's a big deal because of Vichy and World War II and the authority to keep privacy, which is very, very strong in France. In some senses, stronger in France than the United States. They won't even do in France directly observed therapy for tuberculosis because they consider that an infringement of individual liberties and of privacy. So just to situate that. So now we have a program in France where for diabetes, physicians are paid for performance inspired by their neighbors across the channel and by the United States to do H1ABC tests. They're paid more to do it. And that's considered good management of a chronic disease. And the health insurance system has data on who does it and who doesn't do it and which physicians do it better. Should they be communicating that information to the patients? Should they be making it publicly available to everybody since they know it? Who decides? There's another program in France called SOFIA for diabetes management, tested in several regions. In this program, the national health insurance system circumvents the doctor and communicates directly with patients who have diabetes and says, we're at your service, we're a bunch of nurses. Would you like some help in managing your disease? This is a new thing. Should they be doing that and intervening in the doctor-patient relationship? And the reason the health insurance system pays for them to do it is that they know that if the patients get better education, they will reduce their admissions to hospitals. I'll let Andrew give some answers to this because it raises questions of patient autonomy, it raises questions of beneficence on the part of physicians for their patients, and it raises questions of third-party responsibility to share information which is available and which will be available in health systems throughout the world. And I'll end with a tougher case, much tougher case, I think. The expansion of the use of HIV registries in the United States. For the most part, public health authorities have not applied traditional public health principles to the control of HIV, and that's been called in the literature that I've just dabbled in recently, HIV exceptionalism. But now it's my understanding that new research suggests that HIV treatments can reduce transmission. That raises new issues. Should HIV registries, which have been put together in different ways, sometimes patients knowing that they're in it, sometimes not even knowing, sometimes with names, sometimes without names. Should HIV registries continue to be restricted primarily to epidemiological monitoring? Or is there an argument for loosening restrictions on public health uses of HIV registries to identify individuals who may be at risk in the United States of falling out of care? And if they fall out of care, they're more contagious, and if they're more contagious, others, their partners, are at high risk. Once these individuals are identified, the ethical issue is whether to intervene at the individual level and force treatment of those patients the way we force treatment in New York City of anyone who has tuberculosis with directly observed therapy. I don't know the answers any more than the very sad cases you gave to me, but I don't think these problems are going away anytime soon.
Well, very provocative speeches I think we have just now. Now, before I open it to the floor, I think I'll ask Michael to respond to Victor's view.
Thank you.
Michael?
Well, I certainly don't have the answers either, but this is a restraint case that you mentioned, and the feeding case. I mean, it seems to me to be a relatively clear failing on just about every single moral consideration we might have. I mean, I don't think the person was on any substantive, even very thin account of autonomy, they were appropriately respected. I don't think they were treated with a dignified manner, and I think the benefit or value or purpose of intervention at that stage is at best questionable. So I think there's some profound failings going on from what I heard anyway.
Right, please.
Well, thank you for excellent presentations. I have two comments I want to make. The first is that difficult ethical questions are not about what one should do in the absence of other things, but rather a conflict between ethical principles. And I would argue, for instance, in the case of whether a life insurance company should release information, ethically I would say yes, they have an obligation to do so. The challenge is that the company may say we also have an obligation to our shareholders that would prevent that. So rather than it being a single obligation, should I do this, it's because of competing ethical issues, but I think that could advance a discussion of how do we then weigh competing ethical demands. To Professor Kwok, those are very compelling pictures that you present. I would argue that what is important in addressing a lot of bioethical problems is not policy alone, but also education. And so I would say that's what's needed to address the situation of the woman being tied with the NG tube, the nasal gastric tube, is that we need to educate providers and patients about the importance of getting advanced directives. The point at which one wants to start talking about end of life planning is not at end of life. You don't want to make end of life decisions when you're there and you're demented. This is a discussion that needs to start earlier. The problem that we find in the United States and elsewhere is that physicians often are very uncomfortable talking about end of life decisions. Physicians don't want to say there's a point at which we're not going to be able to do anything. What do you want us to do? Physicians like to present themselves as we have great power, we can do everything. And I think what needs to change is to educate physicians about ethics and about the importance of realizing that there are limits to what they can do, and the importance of getting physicians to change their attitudes about the importance of talking about end-of-life care decisions with patients, so that patients make appropriate end-of-life care decisions earlier and make advance directives and include the family, so everyone's in agreement that if I can't make a decision, no, I don't want to be put with an NG tube. So I think education is an important component of both doctors and patients that we need to consider in addressing these issues.
Please. Mrs. Go.
I'm Mrs. Gwen Goh. I'm the chairman of an Alzheimer's NGO in Hong Kong. So my particular interest is in the elderly that get Alzheimer's. Someone asked, when do you start dying? Well, you start dying from the day you're born. Everyone dies. And the thing is, when you're young, though, you think you will live forever. You will never die. But when you get to my age, and there's not many of you in this room that's my age, I'm 80. You have a different idea about death. You don't welcome death, but you're not afraid of it anymore. And the thing is that all these elderly patients in hospitals, which are kept on feeding tubes, they probably feel the same as me. We're not afraid of death. It comes. You know, that's a normal ending of life. And we'd like to die with dignity. We don't want tubes stuck up in our noses. It just prolongs life, from my experience from a personal friend. It prolongs his life for 6 months, a year, with no quality of life. He's just staying in the bed, unmoving. And I've seen patients also that reach that stage that know they want to die. You know, they're 80s, 90s, they've had a long life. And they indicate that by not eating, not drinking, but the doctors take no notice of these signs that they're ready to go. And they put the tube down their nose. I know that the doctors have the Hippocratic oath that they must save life at all costs, but in this modern age, I think we should get past this sticking to this oath. We should allow old people to die with dignity, not with all this pain and suffering. And unfortunately, most of the aged are past the age of being able to say, or past the physical ability to say that they don't want all this fuss about keeping them alive. And I do agree with you that we need education of people, of the families, well before their seniors get to the age when they are unable to make these decisions. And they should have this form signed. I would really say to all of you, get your form signed before you get old. I had mine signed years ago, so I don't want tubes stuck in my nose. Or educate the people by taking them into these hospitals where you have a full ward of elderly people with feeding tubes stuck up their nose, unmoving, out of this world, no quality of life. I had that experience 2 years ago, and I thought, my God, why do the families do this? But in Hong Kong, there is this cultural thing where you respect your elders, and you don't want them to die, and if you do this, then you're showing that you love your parents and you want them to stay with you forever. I think we need to educate the kids that this is not what their parents would want to happen to them. I certainly don't at my age, and when you reach my age, you really know that you're going to die. I mean, that's normal. So why don't you let us go and let us do it with dignity? And let me tell you, I did see a patient whose wishes in UK were observed, because they said there, the doctors, if they display these wishes, they will not overcome it. It's their will. Whereas in Hong Kong, the doctors overcome that will to die. But I've seen the patient, she refuses to eat or sleep or drink, but she smiles and she doesn't talk, she keeps her eyes shut. And in 2 weeks, she died with dignity, in comfort, and that's what she wanted. She was in her hundreds. You know, there's no quality of life when you get to that stage. Thank you.
I just hope we have more than a few peoples like Mrs. Go here. Talking about management of chronic illnesses, I think it has been said that the best way to do it is to let persons or patients or elders themselves actually to make the decision, as well that they could be capacity built to the level that we see Mrs. Go here demonstrating, how much and what she would want towards the end of her life and how she is going to be treated. But nonetheless, Hong Kong is still very much behind her thinking. Behind meaning that actually not behind her, but slower, much slower than her thinking. I think we had a lot to catch up with her. Please, last question.
Dr. K.B. Leung from eHealth Consortium. I'm a patient representative. I think I'm the only one here. Most of you are doctors or professors. And I think the problem we have now is that we don't have much voices in the committees of policies in health policies. And I think if we can have more people more patients in those committees, or also more senior people in the committees for health, for the aging health, okay, then we may be able to spot the problems early, and then our policies can be better devised. Thank you.
Right, thank you very much. I think time for lunch. We had the most vibrant session this morning. I hope this can carry on this afternoon. So do come back this afternoon. Thank you very much. And give a round of applause to our speakers as well.
Thank you,
please.
Professor Chan, Dr. Dunn, Professor Kwok, and Professor Rodwin.